So for week 10, what do we need to know about week 10? Well, you've had your exam. Now you're going to have your discussion question. You do have a CJ Sims this week. Also, you do have your practice exam that's due. Remember, practice exams, it's one attempt and it does automatically go over into your grade book. Okay. If you don't see it in your grade book, let Professor Morris or myself know, and we can look them up, or we can do what we need to do in order to get your grade. Okay, but usually there's one or two students that can't get the grade over. So if it happens, don't worry, we can look it up. It's not a problem. Your grades will be out by about noon, 12:30 on Saturday. We're going to do our item analysis, look together. Two, three maybe questions that I'm seeing, maybe here or there. But really not too bad altogether. So today, what we're going to do is we're just going to do a Kahoots. And we're going to do it till it's done. And then that will be class done. Usually I'm about 5, maybe 10 minutes early today, only because that's the way the class runs. Now, Saturday, I'm doing a HESI Q&A review. It is at 2 o'clock. Yes, it will be recorded. Yes, it will be posted. If you know me by now, it'll be posted on Professor Bogart's YouTube channel before you'll even see it posted to your announcements, okay? So it's Professor Bogart, Pediatric Nursing. Look for the latest HESI Q&A review. And you also have the handouts. If you don't, let me know. I'll send them to you. It's not a problem. Whether you're my class or Professor Moore's class, doesn't matter. I'm lead. I take care of all of you in some way or another. So no worries. So if you want to come, it's that period where I'm trying to make you take what you've memorized and now use that information. You know, how to take and understand the information, just not learning it, because memorization does not work anymore, especially going into your capstone. You have to put it all together and think. And it's as easy as critical thinking. Oh my goodness, that terrible word, right? But you do it every day. So it's just thinking logically, thinking about what do you want and how do you get there simply. And that's what we do with children, adults, our clients that we take care of. So let's go ahead and let's start with our Kahoots. Does anybody have a desire to win a Kahoots today? Or should we pit Morris's class and Bogart's class against each other and see how we do? Or should we just hold hands and not care and go hoorah, whoever wins?
Hold
I like,
hands and not care.
there you go. That is me, completely me.
Trainer for two.
I would definitely say the competitiveness in me is strong, so I would not do a competition.
No, we're not going to do competition today. You know, you don't get anything for doing it more than the other person. It's just if you're that competitive person, want to test your knowledge, this is a great little Kahoots. It covers everything from everywhere. It's one of my old ones that I pulled out, went back, looked at concepts, said, yep, they're coming back again. So after class today, I will make sure both classes have your Kahoots 1 through 9. You also have 2 100 question Kahoots. I believe Professor Morris put there, but I'm going to make sure for you. And I will put up your announcement with this recording and this Kahoot. So there's 2.5 Kahoots, literally. 2 100 questions and 1 48 question. Uh-oh, guys, Albert Einstein has come to take the Kahoots with us today. We're in trouble. Let's go ahead and let's get started. So 48 questions. Let's see. A toddler swallows grandma's digoxin. What are you going to anticipate? What care do you think is going to be delivered? Well, what's digoxin? Isn't like all that stuff you have to check before you even have to give it to an adult or a child, right? So they swallowed something, it lowers and strengthens the force of contraction. It could stop the heart on a child. So we are going to make sure they have digoxin immunofab ready. Years ago, we used to give Epicac and make everybody vomit. We do not believe in it anymore because chances of aspiration, and that's worse than keeping it in most of the time. Okay. What do? Immediately, you call 911 and then get to the ER, right? Sigh. Signs of respiratory distress in infants. Now, respiratory distress in all age children, adults are that restless retractions, you know, uh, that looking, that, cyanotic looking thing, tachypnea, tachycardia. But in infants, you have those nasal flaring and that at the end of each breath called a grunt. And they actually bob with it like I'm moving. That's what an infant actually does. And you hear that grunt, you better be in trouble. That one's going to crunk burn pretty quick. Get them to a resus room because they will stop breathing. When a pediatric patient has an amputation, what priority teaching is very important? And again, amputation, adult, child, doesn't matter. What is your concern? You've been amputated. Let's say it's the below the knee on the right leg. What are you going to worry about? And it's keeping that leg ready to get up, get a prosthesis on, and be mobile, especially pediatric children. You can't hold them down. They want to get up and move. So, as in, we protect that peritoneal cavity for peritoneal dialysis, right? We're going to protect that stump so that we can use it the way that we want it to use it. So that doesn't stop us, interfere us with getting that kid up and out and moving. A multi. What is acute myelocytic leukemia, AML, in children, and what are the symptoms? So, leukemia, ALL, AML. Now, AML is the most difficult to cure. ALL is the most common, and actually, it is easier to cure in children, a little bit less time. Now, leukemia is a blood-borne disease. So let me get you back to you can remember. Blood-borne disease, leukemia, it's a unproliferated production of white blood cells, which means they just don't work. They're just not right. Cancer has made them non-functional. But the cancer just doesn't do that to white blood cells. It's also going to hit your red blood cells. So it's going to affect your hemoglobin and hematocrit. Not only the white blood cells, so now you're worried about infections, it affects platelets. Now you're worried about that bruising and the ecchymosis and petechiae and all of that good stuff. And bone pain is just part of it. Most children that just come in are pale, fever, they ache everywhere, they're bruising, they don't know why. They come in, we do a CBC, we do a smear on that white blood cell, and we see these really weird shaped white blood cells, and we know what the answer is. A multi may be a problem seen after surgery for tetralogy of Fallot. Now, I use the word tetralogy of Fallot, but remember, that is one of the congenital cyanotic heart defects. It's actually the diagnosis that HESI and NCLEX uses all the time versus another cyanotic heart defect. So you've got a heart that was working hard before surgery. Now, after surgery, sometimes the heart just can't handle it trying to beat normally. So it ends up these children fatigue earlier. They get tired easily because sometimes their heart's not working well. The heart's not pumping good. Fluid fills up in the lung. That takes space where oxygen should be getting to the body. So they're fatigued, they have no energy, and then no energy, they're not going to eat. And then you're going to see not gaining weight. It'll be more of tachycardia, not bradycardia. What are defects associated with tetralogy of Fallot? Remember, tetralogy is right-sided, except that little space between the bottom ventricles. That's the only one that I would say could be right or left because it's a hole between. Besides that, everything right-sided. Don't choose anything left-sided on this one. So an aortic stenosis is left side. That comes from the left ventricle, goes to the body. Everything else is associated with tetralogy. Remember, this is the TET spell. This is the needed chest on the infant. You're going to be worried about that pulmonary valve being obstructed, and all of a sudden, blood can't get to the lungs. I have seen O2 saturations go from 100 to 10% within a minute in a TET spell. They turn from pink to blue quickly. So it is one of those things. Right ventricle is going to swell up, and all because of this obstruction. And knee chest it, and hopefully it will pop it open, and the blood will flow back to the lungs. So you're in there and you have an 18-year-old, and the parents want these lab results. Are you going to give lab results to 18-year-olds' parents? This is that fine line in nursing. The last 10 years, I worked in an emergency room. I was the trauma junkie, and then I would take care of just the walk-in rapid care patients. And this was a common thing. 18-year-old parents come in with their child and expect you to tell them everything about their child. It's against HIPAA. They're 18. They're responsible for themselves. Whoever pays for the insurance, et cetera, et cetera. It's an 18-year-old who's cognitively alert oriented. You have to ask them, can you speak freely in front of your parents, and can I give them the lab results? Okay? That's a HIPAA question. I'm guaranteed it's going to be on your NCLEX. Guaranteed. What is synergist and why is it given? I want you all to go back and look at Synagist, indomethacin, prostaglandins. I want you to know where they come from. These are 3 drugs that you will see somewhere. So Synagist is given, it's an RSV vaccine. So let me explain it to you again. This is only the first year of life. These are immunosuppressed premature infants that it's hard enough to suck, swallow, and breathe. And you don't want to put nasal congestion on these children because they're already immunosuppressed. They're already struggling. Infants are obligatory nose breathers. So put mucus in there, now they can't breathe. So we don't want them to get RSV. It's once a month from winter to early spring, and that's it. Okay. After that, remember, it's a virus. What closes a PDA? Indomethacin. What keeps it open? Prostaglandins. Whether it's mommy inside intrautero or a synthetic prostaglandins. These are things you have to remember. Growth hormones, we don't even give it a name. We just tell you it's given sub-Q. Okay. What is the highest priority with a preoperative infant with bladder exstrophy? Anything born outside the body before surgery, preoperative, bladder exstrophy, omphalocele, gastroschisis, myelomeningocele, things are on the outside of the body. What is your biggest concern with these children? And you could go on and on what you're watching, but the biggest thing is infection. Have sterile normal saline, sterile dressing, and really monitor that skin integrity. Because again, you want that bladder inside, close it up. And if you get that skin all scoriated, you're not going to have a good closure of skin. A 10-year-old wants an insulin pump for his type 1 diabetes. Is that a good idea for a 10-year-old? And think about what an insulin pump does. Diabetics give themselves how many injections of insulin a day? And they do blood sugars and they cover it in between, right? Insulin pump, you put one needle in the abdomen, put a nice dressing on it, and you keep it there for almost a week. So you're not sticking these children over and over and over again. When is it a good idea? If they're awake, alert, oriented, and they can take their blood sugars and know how to bolus in insulin, that's all you need. And it's a great thing for them to get involved with. They're taking charge of their own condition. And what you want to do at 10, it's a great time. Multi. Why, when, and why would a Lyme test be done on a child? Mm. So a Lyme test is done in case a person, child, adult, was bit by a tick. Now, there is a blood test, the Borrelia burgdorferi. Yes, that's a blood test that you can do. But sometimes what we see is like little wheals around it, redness. But one of the other questions that comes out with about Lyme tests, children and ticks, is let's say you have a child's friend. Mother calls up, hey, your kid was out with mine today and they were out, at the brook in the field or whatever it was, because it's grassy, it's moist areas like that. And I found a tick on my child. What would you have to do for that child? Let's say she brought her into urgent care. And the thing is, you need to check the child for ticks. Is there any ticks on the body? They bury into the skin. So what we tell them to do is take tweezers and pull it out. And if you don't get the whole tick out, go to the doctor and they can get it out also, okay? Lyme disease sometimes is very hard to detect. And I've actually been involved in it several times here in South Florida, children who were up north somewhere and came and had these weird symptoms. And that's what they found was Lyme. But the thing is, check the child for ticks and pull them out. What might you see after administering a bolus of albumin to a child? So, albumin is a fluid, it is protein. We give this a lot when we see a lot of interstitial edema. It tends to go in the blood system and pull fluid out into the blood system, and then it is excreted in the kidneys. Many times, after we give this protein, which pulls out the fluid, we'll give a diuretic like furosemide. And it's one of the treatments we use for this interstitial edema to pull fluid back interstitially, interstitial back into intravascular. A multi. What is another term for erythema infectiosum? One of the chapters we couldn't get to is all about some childhood diseases. So we've covered the ones that you need to know, but this is another one. And it is a virus, highly contagious with young children. They usually come in and they have a fever, upper respiratory, maybe the big rash is like not just little dots of little rash, but big purplish sort of demarcations. They itch like crazy. I saw one kid had to come in 3 times one day. He couldn't stand the itch that was all over him. But it's also called slap face or fifth disease. Slap face means it looks like somebody slapped them because their cheeks are red. That's what it means, okay? And fifth disease is the other name for it. It's a virus, highly contagious, and that's one of your childhood diseases. It's the treatment for pertussis. Well, if everybody got immunizations, we wouldn't have to look for a treatment, would we? A couple of years back, we had a big breakout of pertussis, and there's one going on with measles right now. And again, the only reason is because not everybody believes in immunizations, so they can get it. Now, pertussis is extremely airborne, and the treatment is as simple as Zithromax, an antibiotic. So again, put them into their airborne airflow room, give them their Zithromax, and within 24 hours, again, these children can come out. How do you get rid of cradle cap in an infant? When you have a little girl, you want to put a cute little bow on her head. They got this white flakes all over, and you're like, oh, I want to make it pretty. I don't want to bring attention. All right, put a hat on for now, right? But eventually, wash it normally with baby shampoo and water, but gonna put some sort of lubrication on there. Mineral oil, olive oil, whatever oil, put it on there and very gently comb it out slowly. And it's not gonna be in one try. It could take several tries to get all of that cradle cap out of there, but that's the way it is treated. Post-operative abdominal surgery child has an elevated heart and respiratory rate. What assessment might you make? What do you think's going on with that child? Sometimes I have paralyzed, sedated, intubated children post-op surgery, and all I'll see is an elevated heart respiratory rate, maybe an elevated blood pressure, and something, it's pain. It's pain, it's telling you, even paralyzed, sedated children, adults, if they're having breakthrough pain, they can't tell you they're paralyzed, sedated, right? But their vital signs are going to tell you, and that's what we look at. Can cause rheumatic fever. You were taught two different diagnoses that is caused by this. Rheumatic fever, acute glomerulonephritis, is caused by not knowing you had a strep infection or not treating a strep infection. So, one of the things when you see rheumatic fever coming in, usually it's that when they get the gait, that central nervous system gait, they're not walking right. And then the fever and the rash, you're like, what's going on here? We say, "Hey, have you been sick recently?" And they say, "Well, yeah, I had a little upper respiratory, a little sore throat." How would you confirm it? ASO titer, an anti-streptolysin titer. It's a blood test. And that, ding, I've confirmed it. And then what's treatment for either of these diagnoses? Long-term antibiotics to treat the strep. Everything comes back except if the rheumatic fever has touched that mitral valve. Once the valve damage is done, it is done. Then you medically or surgically treat it. An adolescent girl wants information regarding birth control. What does the nurse do? Do you give an adolescent birth control information? Do you have to talk to parents? Or just tell her she shouldn't be having sex yet? Every adolescent girl is going to listen to you. No, they're going to do what they want. So, as a nurse, your responsibility. No, you do not need permission. What you can do is only give written and oral information, not your opinion. So you can give them information about, if they want to go and get checkups, Planned Parenthood, if there's one around, or what might be a good alternative. Again, school nurses, this is something that you would see a lot. Hey, they're going to have something, some information. They're going to be asking. A multi. How can you control GERD in infants? Gastroesophageal reflux disease. Remember, in children and even in adults, we don't just like to go right to the, final thing. Be very easy trying to treat these first. And with infants, the first thing to do is to give them a little bit of rice cereal in their formula and then keep them elevated and burp them and not overfeed them. So, rice cereal given, and it could be given at 1 month old, 2 weeks old, if the reflux is that bad. And then you say, but you don't feed them till 6 months. No, you're not going to probably get any nutritional benefit from the rice cereal. You might see it in the stool, but they're not vomiting. They're keeping all that extra nutrition in. So, rice cereal nutrition, it's better to keep it down so they don't vomit. A multi at 15-month-old brings a spoon upside down to their mouth, and the mother said it's normal. A toddler's feeding themselves. Bring the spoon upside down, backwards. Does it matter? I mean, is this a problem you have to send to a doctor? Absolutely not. I mean, toddlers are experimenting. Let them play. Let them figure it out. You can show them what to do, but they're going to do what they want anyway. And you need to give them that independence. Remember, autonomy versus shame and doubt. Autonomy, let me do it myself, automatically me. And you telling them, oh, you're doing it wrong. It's not wrong. There's no right or wrong way to feed. Also, ask the mother why she's concerned. Maybe she knew of a child or as another child there was issues and she's concerned. Okay? Say, how is juvenile idiopathic arthritis treated? JIA. And it doesn't matter if it's juvenile or just adult rheumatoid arthritis. It's all figured out the same way. It's all treated the same way. Um, Children tend to be a little bit better because they get up and move easier than older people. But steroids are the band-aid. You're in a big flare, steroids help, okay? The drug of choice for pain is NSAIDs because they're anti-inflammatories. What is JIA? Inflammation of joints. It hurts. I have it. I know what it is. Also, they start out with methotrexate, whether PO or sub-Q, and then if that doesn't work, we're going to add on things biologic, Humira, Cimzia, or go to infusions, etc. Whatever it does to take it, we'll use it to help. And again, Synagist is for RSV, that monthly vaccine. A toddler's vomited 2 times and he's listless and irritable. What do you tell the mother on the phone? I guess she called you. You're sitting there at the doctor's office. She has a 2-year-old, vomited twice, but she says he's listless and irritable. What is that telling you? What that's telling you is you're getting close to being dehydrated, and dehydration and children is dangerous. It is better get them to the ER. Again, tell them to stop eating, drinking, anything. Get them to the ER, and if they need fluids, we can get them started quick. Honestly, I've seen one big vomit be dehydration. What was their dehydration stat or hydration status before they vomited, right? One, I've seen a heart rate go from on a toddler, should be about 100. I saw it at 180 at rest, and that was one vomit. So it does happen. That listless. It's a clue. You have an adolescent status post amputation for osteosarcoma. He's angry and blaming the parents. Why is he blaming the parents? It's all their fault, isn't it? So think about this child has gone through a loss. He's grieving the leg that's gone. And part of it is blaming somebody. And it's why not the parents? A multi. What should the nurse assess with children with hypo and hyperpituitarism? I'm talking about anterior lobe of the pituitary gland. What does that deal with? Posterior lobe talks about fluid and fluid balances. The other side, anterior, hyperpituitarism, all talks about growth hormone. One of the things that I've emphasized all quarter long is that every child, every visit always gets a height and a weight. And it's for many reasons. Nutrition, are they eating right? Is the growth hormones working right? Is the thyroid hormones working right? We could tell a lot if height and weight aren't where they should be according to standards. A multi. An infant with a tracheoesophageal fistula, what should you have at the bedside? This was one of the trickier questions on the exam. Remember, if you have an opening between the trachea and the esophagus, you're not going to feed that child because they're going to eat, it's going to go right across and it's going to aspirate into the lungs. So, what are we going to have at the bedside? Well, you still have children that have mucus in the mouth. So, some suction if it gets to be too much because they'll gag and choke and they'll turn cyanotic just from that gagging and choking, many aspirations. And of course, head of bed elevated. Simple as that. Absolutely no feeding is done on that child. A child's been having diarrhea for 3 days. What should the nurse check? How are you going to do a quick assessment on this kid? How? I mean, I can look at a child, I can look at their color, look for skin tinting, I can look at sunken eyes. It's an infant. I'm going to look at a fontanelle. But a 3-year-old, what am I gonna look at? I'm gonna immediately listen to a heart rate. If it's elevated, guess what? I know we're dehydrated. And not only are we gonna give oral rehydration with electrolyte solution, if it's the heart rate is too high, we'll be giving some IVs with it. So it could be a combination. So pulse rate, gonna tell you hydration status. What is a VP shunt used for? Ventricular peritoneal shunt. So, when you have a child who cannot make the flow of fluid in the brain go, and they become with fluid collecting in the brain, hydrocephalus, water on the brain. This VP shunt is a little catheter that goes up into the fourth ventricle in the brain, goes behind the ear. On my exam review, you could see like that big knob there. That is where neurosurgeon only can push and pump on it. We leave it alone. We only do head circumferences. And it goes down and it goes into the abdominal cavity. And it just keeps that brain from getting all swollen and pressure being put in there and causing brain problems. What do? Again, it's just head circumferences, and on smaller children, we're gonna do abdominal circumferences. What would you see with a child with autism? I think this is the one that we all know. It's that repetition, repetition. You know, when I did clinicals and I was in one of those prescribed pediatric daycares, this little child with Downs and autism, and I'll never forget him. He would come in, he knew what to do because of routine. Once he got checked in vital signs, he would go in the corner and he would take his toys and he would start the repetition. Take the fire truck, put it on a chair, take a doll, put it in a fire truck, take another car, put it on top, take this, put it on top, take the thing on top, take the car off top, take the doll off top, take the fire truck, and then do it again. Fire truck up. And he over and over, and you could watch him do it 10, 12 times in a row. And I used to show my students it. I said, this is what you call repetition. So why do they do it? Because it gives them comfort. They're in control of it. They know how to do it. A multi. A mother of a child diagnosed with Duchenne muscular dystrophy wants to have more children. What are you going to tell her? What do you know about Duchenne? It's boys ages 3 to 7, progressive muscle weakness. We've got those big hypertrophic thighs. We have lordosis. They tend to be cognitively delayed. And they usually die as teenagers from cardiac or respiratory distress. So, a mother who wants another child, you really need to have them into genetic testing and know that it is an X linked recessive trait that caused the child to have it. So, they need to figure out what's the chances of it happening again. And they are great if they have another boy. A multi. An umbilical hernia has become hard and painful. What should you tell the parent to do when they call you up? Again, they're calling the doctor's office again. It's easier to come in, right? I mean, umbilical hernias are fun, little babies, and they stick out and they're soft and squishy, and I love playing with them. But inside the intestines can twist, and now you are strangulated, you're incarcerated. Blood supply has been stopped. A piece of intestines will die if we don't take care of this pretty quick. Get surgery, get it untwisted, and let the blood come back in. So, what do you tell this parent? Well, they're going to go to surgery, make the child NPO. From that point, then send them to wherever their surgeon's going to be, pediatric ER, regular ER, wherever their doctor is, and because they need surgery right away. What acid base imbalance is caused by hyperventilating? Now, I will warn all of you, I had one HESI that had 4 different acid base questions. Remember, when you have diarrhea, you're losing all the alkaline digestive juices. So if you're losing alkaline, you're left with metabolic acidosis. With vomiting, you're vomiting acid. So what is left? Metabolic alkalosis. And then this is the other piece of the puzzle, and you can remember all of them. When you are hyperventilating, it is respiratory alkalosis. A multi. A child is falling and a stick has scratched their eye. What should you tell them to do? Again, they're calling you up, asking you. They want free medical advice. So whenever you have an eye injury, if we can see things floating, you can take a tissue and get it out. But if it's in there, stuck something, you never, ever, ever pull it out. What you do is you put a Fox shield or a hard eye patch, not those soft ones that will make it scratch and move, but hard and rigid, called a Fox shield. Put it over it, and you're going to send them either to an ER or pediatric ophthalmologist, wherever is the best place for them. I mean, sometimes you have pediatric ophthalmologists in the ER. It all depends. So either or, they need an eye doctor now to take care of them. An infant arriving at the ER is congested, febrile, and has a cap refill less than 2. What should you do? So every child who comes in, you need to be concerned. For instance, we were concerned about chicken pox, right? With macules and papules and fevers and getting them into airflow rooms. You have an infant congested and febrile. What could it be? It's probably RSV. And yes, other infants can get it. So yes, you are going to keep them isolated. Again, putting them in a room by themselves. Hopefully, there's an airflow room to protect the other children and then protect yourself. A school-aged child has reoccurring dermatitis, eczema. What suggestion would a school nurse provide to parents? I mean, this is something that can happen. What if you have a child? Eczema can get hard and crisp and scabbed over, but it becomes open and juicy, and you're worried. The biggest thing is about infection. So what would we say? And this would be your school nurse that might be given this information. So when they're open and juicy, they need to stay home. We need to protect them and their infection. So keep them home until they're better. And of course, you can always send their homework home. I don't know if we have hyperallergenic any foods, but it would it sounds pretty good. And you don't want them wearing gloves all the time. Again, you're bringing um that attention to them. And does the eczema mean it's on their hands? It could be on their arms, could be anywhere, right? So that's not always going to work. A multi. Why do you give aspirin to a child with Kawasaki? Do you remember what Kawasaki is? Systemic vascularitis. Our concern is that this child is going to have a aneurysms of the coronary arteries. This is a child with red eyes and rash and fever and peeling palms of hands and soles of feet. And this child, it's a viral type thing that's causing this to go on. So, what do we give these children? We give them IVIG, boost immune system, and we give aspirin. And why do we give aspirin? Well, what does aspirin do? It thins the blood. So it prevents clots and that little vascularitis, those inflammation of all those little vessels in there. And of course, anti-inflammatory, again, decreasing the inflammation, etc. Now, Kawasaki children don't get pain. If they did, aspirin would take care of the pain, but it's not a pain that they have. It will help with a fever. How do you medically close a patent ductus arteriosus, a PDA? Indomethacin closes it, and prostaglandin keeps it open. Remember, mommy has prostaglandin hormones when she's pregnant. When the baby's born, mommy's supply is gone. So if they had a condition that needed PDA open or oxygen is needed for the body, that's the way they need to get it. We need to keep that duct open because without prostaglandins, it's going to close in up to 21 days, usually within the first week. So synthetic prostaglandin is given in a slow, continuous infusion. Now, you have a little premature infant, they have this PDA open, they don't need it, and we need to close it. We're going to medically try first, and we're going to give indomethacin. Would you know as a nurse at bedside giving indomethacin that that duct is closing? Well, what is the when you assess a PDA and you are listening to the heart, you're going to hear a washer machine murmur. That's part of PDA. It's part of the description of it. Well, if you're giving indomethacin to get rid of that PDA, that murmur is going to slowly disappear and go away. That's how you know. Okay. A child post tonsillectomy is swallowing every 2 minutes. They're swallowing quite a bit, actually. Why? Remember, they take and cut out tonsils, adenoids, and cauterize the areas, and there's big scabs in the back of the throat. And those scabs can come off. And I have watched children bleed out, go hemovolemic. I've had to resus in the trauma room with saline a week post tonsillectomy. So, post tonsillectomy swallowing, just have them open their mouth a little bit. You don't want to go in there, poke anything. You're going to see blood all over the tongue, bright red blood. Get them back to their ENT, to the doctor, usually to the hospital. Most of the time, they have to go back to the OR and cauterize the areas because it's a scab. It's come undone. It needs to be redone. A child is walking on their tippy toes all the time. Why are they doing that stuff? And I've had a friend of my daughter's. She was 2 when I met her, and she all the time is walking on her tippy toes. I told her she really needed to be evaluated by a neurologist because she has a degree of autism. So today she gets all of the therapy, speech, physical, occupational therapy, and occasionally you'll see her on her toes, but much improvement of walking and even the way that she responds to everybody around her. So sometimes that's your little clue, simple as walking on their tippy toes. A multi. What treatment should a child in pain with JIA have? So, rheumatoid arthritis, whether it's juvenile, whether it's adults, number one pain treatment is, give something medically, and those are NSAIDs, whichever NSAID it is that works. And there's all types of NSAIDs out there. Now, hot baths, cold baths. Put me in a hot bath, and I'm going to scream in pain because it's going to make me hurt a lot worse. Put me in an ice bath, and I'm going to go, oh, thank you so much. Now, are everybody like that? No. Which is the right answer? There's no right answer. It's either hot baths, cold baths, or alternating. It's whatever that child, that adult wants. They both work. But with kids, that works the best distractions. Give them an iPad, give them a movie on TV, or start playing, with them a game about something. Distract them, and they forget all about what they're in the pain with. And infant sweat tastes salty. What do you think is going on here? Remember, as a nurse, sometimes we don't have obvious reasons to diagnose anybody. And sometimes it's subtle, subtle assessments that we see. And it could be, I take mom says, oh, this sweat tastes a little salty. You're like, listen to that and test them for CF. It's better to be safe than sorry, right? Sometimes it's that little, they're stooling at birth. It's not one of those. They didn't know the kid could have CF, and it's just that little clue. Remember that. Sometimes it's the little stuff. A multi. How do you diagnose hip dysplasia in the infant? Developmental hip dysplasia. It means they're born and that hip, that femur bone's not up in that hip socket. It's up here at some different level. And I like it when I take my arm up because it's telling me that leg is going to be shorter. That's always number one. And then when you look at those folds of the buttocks, well, this one's going to be higher. So they're going to be unequal. And then, of course, that clicking stuff that's going on, positive ortolani. And then the foot's pointing inwards, outwards. Actually, that's your adult with a fractured hip. You'll either see it in or out, and they put them in Buck's traction. That's what that is. So just wanted to let you know why you've heard of it before. Causes acute glomerulonephritis. What is glomerulonephritis? Oliguria. That is periorbital edema. That is that red, foamy, beer-like urine that's going on. And again, it's a recent strep infection. And again, through this whole thing, acute glomerulonephritis, nephrotic syndrome, nursing care, intake, output, daily weights, fluid. Those are the things that you always monitor. Now, with acute glomerulonephritis, and you're monitoring those things, we're seeing daily weights decrease. We're going to see intake and output, more output, getting rid of the fluid. As we treat them for that strep infection, you're going to see them getting better. Bye. may be a problem seen after surgery for tetralogy of Fallot. This is from the beginning of this Kahoot. Tetralogy, congenital heart defect. Again, which one do you see? Fatigues easily because they are just tired because now their heart's not working and the lungs are filling up with fluid. They have all that oxygen going around. They're working hard to breathe. And they're tired and they're not eating and not gaining weight. Poor little baby. Sigh. A child with pertussis is receiving azithromycin IV. Priority to include it in this child's plan of care. Well, pertussis, okay, breathing issues. Azithromycin, antibiotic. Now, remember, children don't always get antibiotics, and sometimes it's the first time they've ever had one. I know Christian, I think, was 5 years old when he had his first antibiotic, and it's because he had impetigo. That was why he got something. But remember, any antibiotic, always put it on your plan, care plan, that these children with antibiotics can have abdominal GI discomfort or go anaphylaxis, either or. They both can. Why do sickle cell patients have enuresis? How do you treat sickle cell? What's the basic care of a child with sickle cell disease? To keep hydrated, right? Keep those blood vessels open, keep them warm so that blood vessels, cells go through all of the blood vessels. And the thing with all of that drinking, when they go to bed at night, they're so full of fluids, they will be incontinent and have a moment where they have some wetting, and that's absolutely normal. An infant scheduled for a cleft lip repair, which information is priority to convey to the surgeon before surgery. Now, I put this question here because I want you all to go back and look at electrolytes, CBC, normal lab values. You're going to see something regarding it, and you need to know it. Like this question, which one here is just not right? That's the answer to that question. And it's the red blood cells, 2.3 million. It's not normal. Everything else is normal. When administering indomethacin to an infant who has a PDA, anticipate which outcome? So you have a patent ductus arteriosus. You're giving indomethacin. What does indomethacin do? It closes the PDA. So what are you going to see? See how you think here. And that murmur is going to start decreasing. That's the only thing you see here. And last question, when should solid foods be introduced to an infant? So, solid foods, we start with one food at a time every 4 to 7 days. And they say the best food to start with is rice cereal because it's the least allergenic of all the foods. So, let's see how we did today, guys. Number 3, Albert Einstein. Yay! And a Moni. Good job, Moni. And number 1, drum roll, please. Lady J. Good job, guys. Tammy and Jay, it's been a lot of fun. You guys have been really good with this. If you want to see this, again, I told Professor Morris's class, you will see this probably first on my YouTube channel. If you need it that quick, it's going to be there as soon as it comes up. Um, thank you for a great quarter. Even Professor Morris's class, no. Next week is HESI. There is no class. Your class is your HESI. You will be getting posted on your announcements how much remediation has to be done, when it needs to be done by, and when homework is done. Very key things there. Week 12, you must meet the professor. I'm doing 2 classes, usually Professor Morris's does the same sort of thing. Doesn't matter what class you come to, it's brief. It could be 10 minutes or 30 minutes, depends on how quick we get through the students. That's your week 12 attendance. Don't forget to get that attendance, because if you miss week 1 for whatever reason, you could be out of the program. That's why we're so insistent. Please make sure you get here for week 12, just to check in. Again, your grades are gonna be ready for you on Saturday, right after noon. It's been great. Your scores are quite amazing. Your averages are very high. I know my class, no one is at jeopardy because of this exam. You're there or you just need to pass. And if you need to pass, do that HESI Q&A, all right? Or come to me, I will help you.
I have
Even
another question,
Professor
Professor
Morris's.
Beauregard.
Yes.
In regards to, can you give us